Well, good afternoon, and thank you for joining us. I'm Beth Stewart, and on behalf of the Texas Oral Health Coalition, welcome you to our third presentation in our special teledentistry webinar series entitled Teledentistry in Texas, Opportunities to Increase Access to Care, presented by Dr. Scott Howell. As most of you know, teledentistry has the potential to be part of a paradigm shift in healthcare delivery that can play a key role in mitigating barriers and improving health for populations with traditionally poor access to dental care and oral health services. During this session, attendees will have the opportunity to learn how Texas dental providers can incorporate teledentistry into their care models that work best in their practice and for their patients. They will also learn how dental students are being trained to use teledentistry to its maximum potential. Today's presentation will be recorded and placed on the TechSoc website the first part of next week. So I'm pleased to introduce you now to our presenter, Dr. Scott Howell. Dr. Howell is an associate professor and director of public health dentistry and teledentistry at A.T. Still University, Arizona School of Dentistry and Oral Health, clinical advisor for MouthWatch, and a senior Atlantic Fellow for Health Equity. Prior to dental school, Dr. Howell worked as portable dentistry as a dental assistant in Michigan, going to long-term care facilities, detention centers, and inner-city schools. He graduated from A.T. Still University, Arizona School of Dentistry and Oral Health, DMD MPH program in 2014. He spent 1 year at the Swedish Medical Center, GPR, in Seattle, treating patients with complex medical conditions and special needs. After residency, he returned to A.T. Still University School of Dentistry and Oral Health to develop a teledentistry program. Interested in learning more about the broader aspects of oral health, he completed a dental public health residency at UT Health San Antonio in 2019. He became board certified in dental public health in 2020. He has spoken at state, national, and international levels on teledentistry, written extensively on the subject, and has advocated for changes in teledentistry policy and laws in his home state of Arizona. Please help me welcome Dr. Scott Howell. Scott?
Thanks, Beth. It's a pleasure to be here with you all this, well, I guess afternoon for you all, or y'all, I should say, getting to a bit of my Texas roots there. What's so nice is I see a few familiar faces in the attendee list. So to those that I know, hello, and to those that I don't know, it's very nice to meet you. I am excited to get to talk a little bit about teledentistry and how it could be used in Texas. This is something that I've had the opportunity to really explore. So I like to debunk some of the myths about what teledentistry can and can't be. And if you've seen one of my presentations before, you might see some repeated stuff, but the technology is always changing. So I like to throw in new things when I can about what's out there. So let's get started. I'll share my screen here. All right. One thing that as we came up with the title here, when we talk about teledentistry and its opportunities to increase access to care, I think it's really important to stress that this is not the only solution that we need to look to when it comes to expanding access to care, increasing access to care. Teledentistry has been a really interesting tool that's been in the dental toolbox for about the last 2 or 3 decades almost, early 1990s, but it was due to the pandemic when people really started hearing about it. And it's when and more states have been passing laws. So I will talk a little bit about the Texas laws, although I'm not a legal expert. But with that said, I'm pretty impressed with what Texas did in terms of their teledentistry laws. I think there's some good things in there that I will highlight for sure. I don't think any law is perfect when it comes to teledentistry. So I think there's always room for ways to grow, but I think Texas did a really good job in terms of getting a good foundation. But laws change because, again, technology changes, healthcare changes. So it doesn't need to change next year or in 2 years, whenever the next legislative session is. But I think we need to keep the conversation going, and it doesn't just stop with this one law, this one opportunity. So A few disclosures. Recently, I've been funded by Delta Dental of Arizona Foundation and the work that I do at the university. All of my teledentistry work started because of a HRSA grant that I was hired under. As Beth mentioned, I'm a advisor for Mouthwatch, which is a teledentistry company, and I've consulted with various national organizations. One thing, no financial benefits from today's presentation. I love the opportunity to speak on this stuff because I want to get the word out. Two things that I think are really important. I'm not a legal expert when it comes to the laws in Texas. So I don't want anything that I offer today to be your guide to say, go and do this, you can do this now. I want you just to consider some of these scenarios that I think could work under Texas laws, but be sure you understand the policies and the laws so you don't run afoul with any of the dental board or others. The other thing is issues related to reimbursement. Beth and I were talking right before we got started, and some of those rules haven't even been written yet. In my own state of Arizona, we're running into some issues around Medicaid and how we get reimbursed when we use teledentistry. But for all intents and purposes, let's just assume that whatever we talk about today, you might be able to get paid for once the rules are written. But do keep that in mind if you're going to use teledentistry. All right, Beth has already gone over these three things, so we'll get to the next slide. I sort of briefly touched on this. When I first presented on teledentistry in Texas, it actually was at the dental school in San Antonio, and when I was a resident there, and I had the opportunity to talk about the curriculum that we had developed at A.T. Still University to teach our students. But the very first question I got, and I appreciated the question, but before I even started the presentation, the first question was, are you going to talk about fraud? And what I appreciate when people ask questions that challenge new ideas is, where do those questions come from? And I was a little taken off guard because I wasn't there to talk about the practical aspects of teledentistry. I was there to talk about how we teach our students. I was in a dental school. I was teaching about our dental school. But I am no stranger to the fact that there are certain organizations and certain companies that kind of monopolize the conversation around teledentistry. And it's important that we hear all the voices, that we hear maybe some of the others like myself who are working in smaller academic institutions, that we listen to people that have been doing this, like Dr. Paul Glassman for 20 plus years, probably at this point. Paul's been working on teledentistry. And that a narrative from one side of the discussion isn't the dominant narrative, because the challenge I've been seeing as states have passed laws, and I'm not picking on any one state in particular, Ohio. Okay, I'm picking on Ohio. Some of the laws that are created, I think, are in response to a narrative that doesn't frame what teledentistry really is. For example, only periodic exams, only limited exams, and they have to be live or synchronous. Well, in areas where the internet connection isn't that great, a live or synchronous teledentistry visit is not going to be a feasible option. So we need to consider the asynchronous modalities also, so that all patients have access to teledentistry, all communities do. So that's where a lot of my presentations come from. Let's debunk some of not even debunk the myths, but let's widen the understanding of the applications of teledentistry. So this is just a copy and paste or some of my summaries of what I saw in the teledentistry law that I think are interesting. You can just see sort of the definition here. One challenge that I have is that anytime you require an in-person visit, it kind of defeats the purpose of teledentistry, of using teledentistry. But simply put, dentistry requires some sort of tactile examination at some point. So I think what's important is that teledentistry, you are going to have an in-person component, but it doesn't necessarily have to be with the dentist. Now in Arizona, that works because I can work with a hygienist who's allowed to go out and collect data for clinical purposes or diagnostic purposes. The hygienist collects the data, I take those data and interpret them and come up with the diagnosis, such as perioprobing, vitality testing on teeth, cold testing, things like that. The hygienist can do that in Arizona. So I don't want to say that hygienists can or can't do something in Texas, but I will say the 12 months, the in-person with the same dentist or a different dentist, that's something I think should be revisited, but it's okay for a place to start. Something, no controlled substances, this is the one I really like that Texas included. the must contact or attempt to contact a patient within 6 weeks. The reason I like this so much is that teledentistry for many of our patients is just introducing them into the healthcare system. We can't just assume that meeting them over Zoom or meeting them, maybe a hygienist meeting them in person and the dentist reviewing the data asynchronously, that doesn't mean someone has access to care. It means that we've introduced them into the healthcare system, and now we've got to get them to the right place. If all they need is preventive care, then they see the hygienist. If they need endo, we need to get them to an endodontist. If they need general dentistry, we need to get them to the general dentist, and so forth. It's not about stopping at the teledentistry visit. So I appreciate that Texas said attempt to contact, because we also know, as with many of my patients, phone numbers don't work, voicemails are full, or the patient just doesn't contact us back. I particularly work with kids in detention, and so we're contacting guardians a lot of the time. And sometimes dentistry, as we know, is just not on the top of the list of priorities. So they might not contact us back. But teledentistry and care coordination absolutely have to go together. They can't be done separately. And I really like that Medicaid must reimburse at the same as in-person rates. That's just another thing I thought was good. Another couple things. I mean, this is all sort of, I would say, not surprising. Who can use teledentistry within the state of Texas. The one thing I did see that was a little confusing is in the law, there was something about no controlled substances, but in the rules that I came across, you could prescribe opiates for 2 days only. So I would say if you're going to use teledentistry to prescribe opiates, in my practice, I don't even have my DEA license anymore because I haven't prescribed an opiate in 7 years. But if you do decide that you want to just prescribe opiates, I would only personally do it if it were a patient of record. I wouldn't do it with a patient who I've never met before. For example, our oral facial pain provider, he does prescribe opiates for his patients dealing with chronic pain, but he knows them. Or antibiotics, absolutely. I'm comfortable prescribing antibiotic if I can see some kind of swelling, but then I always recommend over-the-counter pain meds. I want to applaud Beth and the team at the Texas Oral Health Coalition. If you haven't seen these documents yet, I encourage you to check them out, because there are not a whole lot of states that I have seen that have put in this kind of work to help guide the providers to having successful teledentistry program, if you will. These documents break down a lot of the ins and outs. I like the checklist for those that need something quick and easy. And even the informed consent is great, because that gives people a place to start, in just terms of what are they going to talk to their patients about. So please be sure to check out these guides and these checklists and make them part of your toolkit if you don't want to use teledentistry in your practice. So this is a slide that I throw in probably every presentation I do on teledentistry, and it's something I've basically already said. We've only begun to scratch the surface when it comes to the technology. And what do I mean by that? When you think about it, our dean at AT Still University Arizona School of Dentistry and Oral Health, I love the way he says it when we had a faculty meeting. He said, we're not teaching students to be doctors and for 4 years from now. We're teaching them to be doctors for 30, 40 years from now. And he used the analogy of an iPhone. iPhones came out more, I would say, ubiquitously, the more prevalent rather. 2008, 2009 is when they started kind of making the way, but 2010. And when you look at the technology of the very first iPhone, or smartphones in general, because even in Asia, there were smartphones before there were iPhones. Then you look at where we're at now. We've only come about 13 years, and the technology has skyrocketed. When you look at the internet that we used to have, 3G, 2G even, and now we're at 5G. Dentistry is going to be the same way. And this is why I say keep our brains open, keep our minds open to how the laws and how the policies might need to shift as our technology changes. And the way we deliver care is going to change too. The fact that AI is being used to help providers identify anomalies on radiographs or images. How much are we going to be able to incorporate AI into our video monitoring or video recording, video conferencing systems, couldn't find the word there, our video conferencing systems to allow our eyes to not work as hard, but to help us identify things in the mouth that might not be there, or that we might not see unless something points it out to us. I just think it's interesting, and I just pose, keep your minds open, because things are gonna continue to evolve. I also like to throw this in because in almost every teledentistry presentation, because sometimes people wonder, well, what's the reason? I've heard people say, well, Scott, do you really think there's an access to care issue? And that's just a big question to begin with, because access to care doesn't literally mean I can't get to a doctor, right? I don't think this is a crowd. I probably need to break down access to care. But I also think it's important for us to recognize, again, that teledentistry is bringing people into the care system, but it's not a matter of just bringing them in. It's a matter of is the model we're using in this case, or is the system we're using in this case, teledentistry, is it actually helping their needs? For example, if someone doesn't have insurance and we're saying, oh, we'll meet with you on Zoom, but then you have to pay out of pocket, but you have no money, teledentistry hasn't solved the problem there. But if we have someone who they've got a problem and they can't get to us easily for some reason, and we need to tide them over until they can get to us, or when you look at the virtual dental home model where we're incorporating hygienists into communities and they are working with a remote dentist and providing tons of preventive care that results in fewer diseases down the line, there's a lot we can do with this technology. Because simply put, we don't always need to physically see our patients. And I say we, kind of speaking as a dentist, everyone needs to be part of the dental healthcare system. We all need oral health, good oral health. But we also have to recognize that teledentistry allows us to work with teams. And this is where I have to be careful, because I know Texas law is quite different from Arizona law in terms of scope of practice. But at the very least, teledentistry allows us to work at the top of our scope of practice. And we'll talk a little bit about that as we get into it more. Teledentistry isn't a robot connected to a computer that is controlled by a human putting something in someone's mouth. It's a filling, an implant, whatever. This is dentronics, and while it might be a possibility in the future, it's not how we're using teledentistry. Teledentistry is a communication tool. It's not a billable procedure, and there's a big old asterisk next to that, because teledentistry is a tool. And when you look at the codes that the ADA created for teledentistry visits, those codes are interpreted kind of in different ways. In many states, those codes just tell the insurance company, how did you conduct the visit? In other states, I believe like Missouri and California, you can actually get reimbursed if you use those teledentistry codes. So just keep an eye out for what happens in Texas, but just remember, teledentistry is a tool. It's not a procedure. It's not just for rural patients. In fact, I've never worked with a rural community using teledentistry. I've always worked with medically underserved urban and suburban communities. So it's crucial for us not to just think that this is for the folks living in far off places in the country. It can be for folks who just can't easily get to us down the street. We had a patient one day, our resident was conducting a post-op, although I think I ended up conducting the post-op because the resident was behind with patients. And I sat down with the patient on Zoom and I said, how are you feeling? She showed me the extraction site, which was a lower, and I could see very easily what was going on. And she said, I'm really grateful I didn't have to drive to the school. It's only 10 minutes down the road, but I have complex medical conditions. I'm taking care of someone with complex medical conditions, and it's just nice that I don't have to leave the house. So whether it's 10 minutes down the road or 10 hours down the road, technology connects us with our patients, and our patients benefit from it. Lastly, it's not just a buzzword. And the reason this is a big thing for me is because I saw an article that came out, 2022, I would say maybe 2021, when we thought the pandemic was over. Sorry, but maybe the tide of the pandemic is over and people aren't as sick, but this bug is around forever, right? So it's going to be around forever. So what kind of concerned me is that there was an article in some magazine saying, is teledentistry just a fad? If the author of the article had really done their research, they would have known that teledentistry has been around for decades. It's just now that a lot of people started realizing one aspect of that, meeting with a patient on video conference, but it's so much more. It is not do-it-yourself dentistry. I think this is not needed to be explained, but I also like that my friend JD said, hey, Scott, let's do teledentistry, and it made for a great example of what it's not. It's not about the patient picking up their own home instruments. And JD did call this a scaler. He took his knife and he said, hey, I have my scaler. So he knows his dental terms, but it's not do-it-yourself dentistry. I'm not guiding my patients to do something in their mouth that I would not guide an in-person visit patient to do. There are things that sometimes I'll do, like I'll ask the patient, can you kind of feel around this area and tell me how it feels? I still treat it as a subjective finding, not objective, but it helps me determine where and what's going on inside the patient's mouth when I can't physically assess them. Now, when I work with my hygiene colleague who's out in the field, she or he can physically assess that person for me and report back to me what they find, because we're calibrated and they know what I'm looking for. So there are limitations when you are just meeting with someone on Zoom, but those limitations don't stop us from helping people. The definition isn't really necessary. I realize I kind of left this in because I was teaching this to a newer crowd. I was working with the school in El Paso, and I left this definition in when I was modifying this presentation. But what I love about this, and I think this is just my own kind of concocted definition from ASTDD and ADA, is it's all about a patient in a physically different location from the provider. And that location literally can be anywhere. Now, of course, follow the laws, because some laws say you can't, you're not able to treat someone or assess someone who's not in the same state that you are in. You have to have a license for the state that you're practicing in. But if the patient is in one state, is that the practicing state? All those things are just things you have to be aware of. But to connect people in two different locations is a powerful tool. And it's not just about us connecting with the patients, but it's about us connecting with our colleagues too, connecting with our specialist colleagues who might be able to help us on cases. And I'll show you an example of one in a little bit here. Just more information. I think this might have even be in the Texas Teledentistry guidelines, or a document that Texas Oral Health Coalition put together. But I think it's important to know that, while the ADA is not the be-all, say-all on teledentistry, I think as our biggest organized group in dentistry, I think it's really important that we know what the ADA is saying. And they've tried to make some decisions, I think, based on preconceived notions of teledentistry that would not have been good policy. But I appreciate their open-mindedness to hearing from those of us that are working with this technology and seeing our patients in this manner and adjusting their policy based on what people are actually doing and not about fears of what could go wrong. If we start legislating and creating policies just on fears that aren't based in reality, we end up not going anywhere. So I appreciate what the ADA has done and continues to do around this field. So one of the things that, as you see in the ADA policy here, exams must be based on the same level of information as an in-person visit. How is this even possible? This is possible for a number of reasons. We have to recognize that the digging of an explorer around a tooth that it does not have a carious lesion, a visible carious lesion, is a method of diagnosing and assessing hard tissues that we're trying to get away from. And the idea behind that is that when you compare two different exams, one just done visually and one done tactily, you come to the exact same conclusions almost every time. And in fact, the visual exam, you often come to better conclusions than the tactile. Now, that's not to say that tactile isn't required. I can't visually assess a subgingival crown margin. I can't visually assess pocket depths. And this is where teledentistry as a team becomes really important. And this is the narrative that a lot of people aren't aware of, that teledentistry allows us to work as teams. So when we talk about consistency with in-person visits, we're talking about the broad range of applications. So we'll come back to that in a second, because I think I rearranged my slides and I'm just realizing that. But biggest misconception in teledentistry is that it looks like telemedicine. And that does come back to the issue of, well, how can you diagnose if you're not physically there? Most of what we see in telemedicine, and I'll throw in telepsychology because that's probably the biggest one, are those one-on-one interactions with someone on Zoom, WebEx, whatever you're using. The historical use of teledentistry has never been about just the doctor and the patient. There's always been someone else involved. I would say it wasn't until COVID that it really became just about two people on camera with one another. And so when we think of teledentistry like telemedicine, how our physician and nursing and medical colleagues in general are using technology, it's not going to look the same. There's similarities, but it's not the same. So this is just sort of reiterating things that I've already mentioned, but the pandemic The pandemic made me realize how much the private practice world and the dental community at large, the oral health community at large, is really not familiar with the use of teledentistry. So I greatly appreciate these opportunities to share what we've done in the world of us that are using these technologies. And again, nothing reiterated that hasn't really been said here, except for the public and community health settings. I always hear people talk about, oh, teledentistry is really aimed at the underserved. It's not. It's aimed at anyone that just wants make it easier to get to their provider. I'm not an underserved individual, but I choose a telehealth visit anytime I possibly can because I don't want to drive to the provider because my schedule doesn't allow for it, or it's just easier for me not to have to leave work. My needs aren't that different from anyone else's needs who they don't want to leave work. It's easier for them to visit their provider from where they're at. Again, but it comes down to who is the patient meeting with and how are we conducting those visits? And that's where our examples are going to come in shortly here. The wide breadth of teledentistry applications. I just want you to remember the wide breadth, because as we go through this, I hope you'll see there's no one way. So what am I talking about here? What does teledentistry look like in I'll say an ideal world, but I would say in a world that Texas providers could implement these solutions within their healthcare systems? I always look at it as who's going out into the field. This was the way I started working with teledentistry. Who's going to go out in the field to meet with the patient so that the doctor can use their time efficiently in the clinic? This works under certain laws, and certain ways it doesn't work. But the way we were able to make it work is working with a hygienist. Now, depending on the state that you're in, the locale that you're in, it could be a dental therapist, dental assistant, maybe community dental health coordinator, or a promotora. An individual who's with the patient that is either moving a camera around the mouth while we're on live, maybe on Zoom together, or it's about someone taking the appropriate clinical records that I will review at a later time. And Dr. Paul Glassman was the one who implanted this idea in my mind that the dentist becomes the surgical specialist. And we take those procedures out of the office that don't need to happen in the office, preventive care, exams, and so forth, and we move those to community locations. So for a lot of people, a lot of offices, if you're not working with a long-term care facility, or you're not working with a school, you might not use this type of method where you're sending the hygienist out. But what if you're a private practice and you're down the street from a major corporation and the laws are applicable in such a way that you send a hygienist to that major corporation? You don't fill your chairs with a bunch of people who really don't need a lot of work. That's not going to generate a lot of revenue for the clinic. You keep the lower revenue generating procedures in the field, and then you bring in the surgeries, the crowns, the bridges, the endo into the dental clinic so your chairs can be used more efficiently. And what I really like is that when I'm working with my hygiene colleagues and they're going out, and we do a lot of triage with our kids in detention, I know exactly what's coming into the clinic. We're not taking up time for an exam, and I know we're going to do a surgery. So we're not spending that time taking x-rays. We're not spending that time diagnosing the tooth. We have the diagnosis ready to go. We get the patient in and keep them there for as short as time as possible so that we can turn that chair over and be more efficient with our time. Does it always work like this? No, of course not, because healthcare is unpredictable. But if you can get a good system down, a good communication with your dental team, you can get all the information you need without needing to physically assess the patient. But when the patient comes to your chair, you're going to double check things and then go. And why does this matter? Because how many of us have had an emergency exam come in and we have no clue what they're coming in for? They say the tooth is broken. That could mean any number of things, and we don't even know what procedure we're going to set up for. If we know what we're going to set up for, again, it's those seconds of time, those minutes of time, but things will move faster. This is the type of teledentistry that I would say those that laid the groundwork, this is what they were doing. They were working with community-based teams to coordinate care. That's not what we saw in the pandemic, but the pandemic also opened my eyes to what's possible with technology. So my big phrase here that I like to use is top of your scope, top of their scope, toys and tots. So whoever you are is the your, and your team is the their. So in Arizona, I work with a hygienist who can go out do the perio probing. Well, she oversees our students that we work with, but they are that dental colleague is out there because that's sort of the non-revenue generating. That's not where my time is needed as the doctor in this scenario to be collecting those data. But I also don't necessarily need to meet with the patient to know exactly what they need as long as I have a good relationship with the hygienist. And that's crucial. We'll talk a little bit about that when we come to the education aspect and what we're teaching our students. But we need to know the laws around our dental team, who can do what, and we need to know how we can best work with them. These words may not be unusual to all of you. You may have heard them at some point or another. The four types of technologies that most people are going to hear about are the top four here, and I'm going to give you examples of all these in terms of how we've been using them. I use direct-to-patient as sort of a sub-technology of the real-time and store and forward. Direct-to-patient to me is when the patient themselves are collecting the data and sending it to the provider, as compared to a hygienist, a dental assistant, a dental therapist out in the community collecting the data and sending it to the provider. Because simply put, direct-to-patient teledentistry has extreme limitations as compared to a healthcare colleague out in the field collecting the data for us. But we'll talk about some of those as we look at the examples. Synchronous, I had never used synchronous prior to the pandemic. I thought it was too complicated. It takes too much time to organize. But then working with a clinic in Central Phoenix, I had a hygienist colleague out there, and we were just working with some really complex medical conditions. These kids, I had patients out there on 30, 40 medications. And she was just seeing some very unusual presentations, and she wanted me to see it live so I could talk to the guardians. And once we started doing it, I loved it. She would text me and say, "Are you free for a teledentistry visit?" I would then go and send her an email through secure email with a Zoom link, HIPAA compliant Zoom. We'd log on all at the same time. I could talk to the guardian, I could talk to the patient. And I had the data that much faster to make a decision. I also, the biggest benefit was having that conversation with the guardian themselves, because I could make a lot of assumptions about what the next steps are with an asynchronous model where I'm looking at the data later on. But with synchronous, the video feed was still pretty good, and I could see the big stuff. The little stuff I might not be able to see, but I'm not billing an exam because I don't have enough data. But I am doing a consult and triaging so I know what the next best steps are. This was a patient that we saw, and the hygienist said, "Can you take a look at this?" And he just had what I call a bouquet of premolars. Patient and I discussed this, and he didn't have any concerns, but he knew he had to get them extracted. This was a patient who is on the autism spectrum. So there were some guardianship issues we had to make sure were clear so that he could get the care he needed. He had no other dental concerns, and the hygienist didn't see anything of concern except these little bouquet of premolars, which were both on the right side. There was nothing on the left side, normal premolar presentation on the left side, but his right side, it was really unique. I had never seen that before, both upper and lower. And so that was nice because the hygienist can move the camera around. I see it right then and there and have that conversation. This was a young patient who presented with various medical conditions, severe oral disease, and I was able to talk to mom. I was able to evaluate the patient live, and it only took about 20 minutes. It didn't take that much longer than an in-person exam, and the hygienist and I worked together like we would work in person. It's just because of the nature of that clinic, there really wasn't space for me because it was a hygiene-only clinic. We're allowed to do that in Arizona, and this just made a lot of sense. It was great, and the patient was the most well-behaved patient, tiny little mouth, and kind of big camera, but I can see exactly what this patient needs. He needs a pediatric dentist ASAP. And we were able to coordinate care. And a few months later, this patient had undergone his care and gotten the dental work he needed. And it just took a phone call. I called a pediatric dentist. He said we'd be happy to see him. So it wasn't me intervening necessarily, but I was the one that was able to make the best call. Obviously, the hygienist could see this, but way the laws work, you can't diagnose as hygienist in most states. So I still had to be a part of the team, but for like 10 minutes at most, a little bit more talking to mom. Storing forward, we're collecting the data now and reviewing it at a later time. Now, this is how I typically conducted our teledentistry visits when we were working at the detention center. You can see our portable equipment here. We would set it up. We would work on the youth in the detention center. The hygienist and the dental students would collect all the necessary, still do collect the necessary information and send it to me, and we make a decision. This was a case, this actually was not from the detention center, but this was a case from the first clinic we talked about, the clinic where we were doing some synchronous teledentistry. But before we were doing synchronous, we were doing asynchronous. And this case is always interesting to me because this was, again, a case that I wasn't going to be able to manage in what I do. But I could send it to my oral medicine colleague and I could say, Dr. Patel, what do you think of what's going on here? So there wasn't, this patient, they needed a cleaning. They didn't eat anything by mouth because they had a G tube. So we weren't super worried about caries rates because no substrate, nothing to create caries. But I was worried about this growth, and the hygienist identified it first, and then she took some pictures and sent it to me. And I said, given the patient's medical history, he's on a lot of medications, a lot of medical conditions, let's refer to oral medicine. And I always like to tie this back to an example in Brazil, where a program down there did the exact same thing with oral medicine. A physician or a general dentist would see something in the mouth, take a picture of it, send it to an oral medicine doctor in Brazil. This all happened within different states in Brazil. And that person would then evaluate and give information to the physician or the general dentist on how to manage the oral condition, or they would bring the patient in. Now, prior to using this technology between colleagues, the patients would sometimes have to wait up to a year to get that in-person visit with the oral medicine doctor. And if you have squamous cell carcinoma, that's a death sentence. That year-long waiting list, once technology was used and teledentistry was implemented to streamline the reviews of cases, that year-long waiting list went down to 1 month. And I think that is a phenomenal outcome just by using technology. And it's two providers communicating, which is so crucial in how we use teledentistry. And that's the message we need to keep getting out. It's not just about the patient to the provider. It's about teams of people coming together and communicating. This particular patient did not show up for the scheduled appointment, unfortunately, and I don't know, it was lost to follow up, the case was, but I had the resources at my fingertips because all I had to do was send it to my colleague and say, what's the best way to handle this? And she could help me because this was not something I was comfortable managing, given all the complexities around the patient scenario. There are a couple other technologies that I want to touch on. I'm not going to read this. I'm going to skip ahead. Nope, I'm not going to skip ahead. I'm going to go back one. The one technology I don't really dive into is mHealth. mHealth is us wearing smartwatches and step, what do they call them? Step meters and things like that we interact with, but that our healthcare providers are not interacting with. And they're really easy to ignore. And the data are a little weak in terms of health outcomes when it's just the individual interacting with their smart device, as I gesture at my invisible smartwatch here. However, remote patient monitoring is an interesting area in dentistry that is just beginning to get discovered and explored. And there are 3 companies here. I do not work with any of them, but full disclosure, I have had numerous conversations with the company Toothbrush because I find their product fascinating. So this one on the left is an ortho company that helps orthodontists monitor their patients rather than having them come into the office. I encourage you to check it out. Beam is, oh shoot, I think this is actually an old link, but it should, if you just type in Beam Insurance, if this is something you're interested in checking out. Beam is an insurance company that if you use their connected devices, you can get toothpaste and other bonuses and benefits and maybe even discounted premiums don't quote me on that, but there are ways that you connect with the insurance company that you benefit from. But Toothbrush, what is really cool about this, and I don't think any laws could or could not dictate how we use this. It's just this technology, nothing's going to reimburse you for it directly. This technology is a little device, about $20, $25 you put on your toothbrush, and it sends 1,000 different data points back to the provider. And the provider can use that information to guide the patient. We can remotely monitor the patient. So you have a list of patients that you're doing a lot of fixed crown and bridge on, or fixed prosth on. And these are patients that if they don't take care of their brushing at home, all that work we put in is gonna crumble. So we can give them, the doctor just gives them this easy little device. We hook it up, you connect it to your smartphone, you connect it to the doctor's portal, and I, as the doctor, or working with my team, the assistants, the hygienists, whoever, can monitor and see how you're doing. And if we see that your crowns are failing, but we see you're doing a pretty good job brushing, Well, let's talk about it. What else is going on? Or if we see, you know what, you're not doing the best job brushing, so we're worried about how your crowns are going to go, then we can have that conversation. But simply put, there's never been anything to hold our patients accountable. And I include myself in this, because even when I was practicing with this device, I learned that although I brush with my left hand, it's just because it feels more comfortable. I'm actually right-handed. I found out that I brush much better with my right hand because it measures circular movement and how fast you're brushing, and it measures whether or not you stop brushing. And I was like, wow, that's fascinating. I do a way better job with my right hand, but I still went to my left hand because it felt more comfortable. It doesn't mean, change is one thing, but knowledge is the start to change. So if we can start being more knowledgeable about our patients' habits, it can help us help our patients better. And for such a cheap device, this is something that any patient can use, and it goes on any toothbrush. Whereas something like Beam or some of the Colgate Oral-B toothbrushes, they're expensive, and you have to use that toothbrush. This device goes on anything, electric or manual. I encourage you to check it out. Really interesting. It is a startup company, really interesting model that I think if we can ever get reimbursed for providing preventive, health guidance, I think one day that's a possibility, like value-based care. This is a huge game changer. For now, probably not going to get reimbursed, but at least we can be better with our patients. And then the direct-to-patient example, this was the very first patient I met over Zoom synchronously. And, people have argued with me, well, how could you actually know what was going on? I can tell you what's going on. They tell me that the lower right hurts and number 31 is clearly broken. I don't see any facial swelling, so I'm not worried about an infection, but I can talk to the patient and say, you know what, I don't have an x-ray, so I don't know how complicated the extraction might be, but I can very much see your tooth needs to get extracted. What do you want to do? And the patient said, as long as I know that I'm not going to die tomorrow, I'm okay with that. You gave me some hope. And if at the end of the day, all I did was give my patient hope, I feel pretty good about my day. I'm fortunate enough that because I work in academia, I'm not as worried about the finances, but I would hope one day all of us could walk away from our day saying, it was a $0 production day, but my patients walked away with hope today. I don't need every day to be a $0 production day, but there is something there that's why we go into healthcare, is to help people. And it felt really good. Granted, this patient had other barriers to getting to care, and I was worried because he wasn't going to seek it now, but that's his choice. I gave him the informed consent. What do you want to do? And he made his choice. Just a summary of the modalities, don't need to read through it. So now we're getting into the education component, and this took a little longer than I meant it to, so I'm going to go a little bit more quickly, but hopefully you get a sense of what we can do with the technology, what you might be able to do within Texas. But now it's about how are we preparing to use the technology? And these are different questions that I have to ask myself so that when I teach people, when I teach students how to prepare to use teledentistry, these are the things I'm thinking about. It has to do with technology, working on a team, not touching patients like we've always had, or trusting someone else to touch the patient and assess for us, collect data for us that we then use as doctors. But this is, I say we because that's who I am. But again, this is a team approach. So I don't want anyone to feel left out if I'm not saying you or your expertise, because I couldn't do this without my entire team. Again, a technology question and a patient-ready question. We're not going to touch on patient-ready as much today. We're going to focus more on getting our providers ready, but patients just have to be just as ready as we do too. So things that we talk about that I teach when I'm working with students is the scope of practice of dental team members. It is focused on Arizona, but I want my students, when they work with their hygiene faculty, to know what are hygienists legally allowed and capable of doing, and what are they not allowed or legally allowed and not capable of doing. Now, what hygienists are capable of and legally allowed are two different things, and I will stand by that until I die. But until the law is changed, that's the way it is. We need to understand how to collect those digital records so that they're diagnostic, and using those digital records to diagnose. And that comes down to when we don't have enough information. People think, well, you're going to abuse teledentistry and just bill all these exams and you don't have enough information. If I don't have enough information based on the data that's in front of me, then I can't bill an exam. Just like when I work with patients with special needs who won't open their mouths because of whatever fear they might be experiencing, because that's a fear reaction, is to keep our mouths closed. I can't bill for an exam. Maybe I could do a consult fee, but I can't bill an exam because I haven't examined the patient's teeth. And teledentistry is no different. If you don't have the appropriate data, you can't bill. So knowing what the appropriate data are is really important. Now, Data might be different for different people. How much data you need, what you need to see. I have my protocol. You need to come up with your protocol, but you'll get a sense of what I do with the team I work with. And again, it kind of all ties together. Are you comfortable not touching the patient as the dentist? And is the hygienist, I really should add, because I teach dental students, but for dental hygiene, are you comfortable collecting the data and talking and having an open conversation with your doctor provider? So what do I teach the students to do? It's really important. Now I'm teaching dental students, but they hopefully will teach the hygienists that they work with. We want to have the necessary clinical structures in our photos. Do you have all the clinical structures? Do you have the MGJ? Can you see the entire tooth? Are there shadows? Are there parts cut off? If I can't see everything, then I don't know what's not there. We talk about how do you even take a good photo. Oftentimes I work with people. I got to teach this lab to folks in Rhode Island, and I get it. People have been practicing for 20, 30 years. They have their ways they like to do things, but teledentistry is not necessarily the same way we've always been doing things. So I have lots of different tips and tricks that I work with the students, how to hold the camera to best manage it when you're working in a teledentistry environment. Not when you're just taking a quick picture, to send to, or for patient education, or maybe to send to the insurance company. We're taking pictures for diagnostic purposes, so they must be as perfect as possible. I know perfection is such a long shot, but we're going to try to aim for it. And different things such as how do you make sure the camera isn't distorting the image? Just like when we take radiographs, you distort it, you're not going to see what you need to see. So I'm really picky about the way the students hold the cameras, because if they send me crappy photos, now you've wasted all of our time. But here's the other thing. Sometimes crappy photos come in and I talk to my hygiene colleague, hey, what happened today? I'm not just going to assume that they were lazy. I'm not going to assume that they just were rushing. Don't make assumptions when the data aren't what you need. Have a conversation. And teledentistry, to be successful, you must have an open dialogue between all dental team members. When the dentist is asking the hygienist to do something that is physically not possible, the hygienist has to feel comfortable enough to go to the dentist and say, I know what you need, but here's the challenge I'm running into. Power trips and egos have to be at the door when we are working in separate locations, and we can't be there to fix it right then and there. We have to have a safe place. But my hygiene colleague knows that if I'm not happy with something, it is an open door that I can go to her and say, Colleen, I'm concerned about this. What happened? It's a two-way street. There's no hurt feelings, but we have to know what both of us needs. And if we don't know what each of us needs, we have to be able to talk about it. One thing, again, we talk about videos. No one up to this point has recorded videos in the mouth, but we record videos. And live synchronous exams, I need a very clear video. And so we give the students a demonstration of how do you take a video of the mouth. I have practiced time and time again. You can see in the video on the right, we now start on the lingual. Why do we start in the lingual? Because we used to start on the buccal, but by the time we would get to the lingual, it would be so filled with saliva, we couldn't see anything. So we created a little quick kind of S-shaped motion where we start on the posterior lingual, make our way to the midline. Now, why do we stop at the midline? Why not go all the way across the mouth? Because it's exhausting. The patient doesn't want to keep their mouth open that long. And I mean, they don't want to keep their mouth open long for procedures alone, but with this big camera in the mouth and you're trying to like twist your hand all kinds of ways, a 90-second, a 60-second, one quad video, I can do a full physical assessment or a visual assessment on this patient in about 4 minutes if the person managing the camera goes pretty quickly. But that's really important. We have to know how to collect these videos because, again, if people are collecting videos that don't have the necessary data, how can I help the patient as the doctor? If I am not telling my hygienist colleague, this was the biggest mistake I made with Colleen. We were like, okay, let's go do it. We know what we're going to do with teledentistry. Colleen, take the students into the field and start recording videos. Here was my mistake. I never taught Colleen how to record a video inside the mouth. And you know what happened there? I would get 5-minute long videos of just one quadrant. And I was just banging my head against the computer or the desk because I was tired of watching like 20-minute videos of the entire mouth. And I realized, wow, this is a team learning effort. I can't just send someone into the field and say, go collect data. We have to be on the same page. So it's not just about teaching students. While I want the students to understand how the data is used and collected, I have to work with my colleagues too. So it's so crucial that the team works together to decide how are they going to use teledentistry. The patients over video conference, this is the last thing that I work with. I started working with students and also working with our residents, just being on camera with a patient. What visits might you use it for? Obviously, something you don't need to physically touch yourself, but even then, there are things you can still see without physically touching. We like to use it in our clinic. We use it a lot for treatment plan presentations instead of having the patient come all the way back. We do a lot of post-ops, assuming there wasn't a complicated surgery. But I will say mandibular is way easier to assess than maxillary, especially the posteriors. But almost any mandibular surgery we can easily assess because a lot of it's just based on patient response too. And if the patient's in pain or having problems, they come right in. We had that one case, mom was worried about her son with special needs. He was in a lot of pain post-surgery. We couldn't even look at his mouth and he told me it hurts a lot. And I said, all right, time to come in. But 90% of the other patients don't need to come in and I feel comfortable as long as I can see what's on camera. The other thing we talk about, we've already seen this guy. The other thing we talk about is, if someone's going to take their own images, if the patient's going to asynchronously send you images, you want to make sure that they know what kind of image they should take. So with MouthWatch, we created a document to help guide providers and patients, but I wouldn't just tell a patient, take a picture of your tooth. I would have a diagram of what the patient should be doing so that they can mimic it, so that you get what you're looking for. And then lastly, the other thing that we talk about is, again, preparing the patients, is the provider has to know what are you going to say to your patient to introduce teledentistry to them. And there are certain questions you should ask. The lack of knowledge around technology is not a reason to not use technology, but it is on us as the providers, as the clinic, to help our patients use the technology. So if you don't have someone on your team that can field patient technology problems, then teledentistry you might not be ready for teledentistry, but I guarantee you more people are ready than you think are. And don't necessarily say your older patients aren't ready too, because 60% of older patients have a smartphone. And that number is only going to continue to rise because the next generation, 90% of patients have a smartphone. So do you want to be prepared for the next generation or not? And lastly, we have a checklist that we just make sure everyone knows what they're supposed to do when they're on camera. There's a few things that we want to make sure. We don't want to be looking up anyone's noses. We don't want to have a bunch of clutter behind someone's head that the patient might get distracted with, and other things that we talk about that aren't typical of an in-person visit. But being on camera is different than being in person. In Arizona, we can get verbal consent, which is a little bit different than Texas. But again, just some rules. What do you need to know when you're on camera with a patient? And if you don't know these, are you creating a good relationship, a good rapport with that patient? Yes, the answer to this is yes, but remember, there are limitations with everything. Phone calls are teledentistry. Let's say this. Phone calls are teledentistry, but teledentistry isn't just phone calls. I think that's the best way to say it. Remember your limitations. Do you not need to see something? If you don't need to see something, then a phone call could work. We have a website for videos about being on camera with patients, for patients being on camera with their providers. You're welcome to check that out if you would like, if you scan the QR code or use the link atsu.edu/asdo-teledentistry. These tabs right here will take you to information that you can work to train yourself, train your staff, and train your patients. It's very ASDO specific, it's Zoom specific, but the general concepts are still the same no matter what platform you use. All right, I left with 5 minutes. I probably was supposed to leave more time, but I hope I answered any questions that may have come through as we were going through that. Deanna just mentioned the National Mobile Teledentistry Conference. Yes, I highly recommend it. It's a great conference for those of you who want to learn more about teledentistry and mobile dentistry. Really great organization, the National Mobile and Teledentistry Alliance. So thank you, Deanna, for throwing that out there. I don't see any questions. I don't see anything in the chat, but what's on your minds, if anything?
Well, as we wait for someone to type in a question or raise their hand, I do want to say thank you for putting that in there about the provider giving tips and teaching the team, the dental team, how to take pictures and how to do the video. I did chuckle when you said the 5 minute on the quadrant video. I'm guilty. Guilty.
I would get very nauseous watching those.
Oh, that was funny. Very good comprehensive overall information, Dr. Howell. Thank you so much.
My pleasure.
Do we have a timeline for Texas Medicaid? That's an excellent question. I haven't heard one. I've been told last summer it was maybe in the fall. That didn't happen. As far as I know, it still hadn't come through. But we're waiting.
I would encourage folks to reach out to Medicaid. I mean, be an advocate for your patients and say, we really need to move on this. I don't know if your Medicaid system will respond to those types of advocacy calls, but if they see that people are interested in using teledentistry, they may be more willing to move the ball along. Doesn't mean it's going to happen, but if we don't speak up, then all we can do is, we can't blame just Medicaid, I would say.
That's a great idea. So feel free to contact HHS and our Medicaid dental team if you've got any questions. Are there a schools or training program for staff, dentists, people out of the dental school?
That's a great question, Mark. I did teach this at the National Mobile Teledentistry Conference last year. I taught how to take intraoral photos and videos. I would say keep an eye out. Mouthwatch sometimes sends me out to different conferences, but I don't know of anything right now. I know that there are some programs being designed online, but the in-person stuff is really great because you can play around with cameras and really get comfortable with it with someone in the room with you. So I would just keep an eye out for conferences. Maybe we can convince the ADA to do it. Maybe we can get out there. ADA hasn't embraced teledentistry the way we have in public health necessarily, but I think if enough people were to ask for it, they may bring it there. Or ask for it for your local regional conferences, hygiene, dental, whatever. Make sure people know that you want this information.
And I will say that your picture guide that you did for Mouthwatch, that is also linked on our teledentistry page. And Elizabeth Stanford has her hand raised. Elizabeth, I think you're unmuted.
Okay, hi, can you hear me?
Yes.
Okay, hi, this is Elizabeth Stanford, and I do work for the Department of State Health Services in our Children's Medicaid program. The latest update we've had on teledentistry, it's still there. They're working on some of the wording, things like that. Our legislation has, is meeting currently. I personally don't know the extent of what they will approve for the teledentistry, but I know though that it is on their, they are working on it. So, reach out. I think this really does need to come from the dentist that want this. And of course, Beth is leading the way on all this. We have discussions about this, that it needs to, I think, come from them. Always contact your legislators and let them know that this is important. And I really like you saying it's not, just for the Medicaid population. This is for anybody. I think with Medicaid, though, we can be the frontier people in this and leading the way for this. So it's still in the works. Like Beth said, it's taken a little bit longer than we thought it would, but it's there. I just wanted to give that quick update. And thank you for the presentation.
Absolutely. Yeah, we appreciate you letting us know what's going on. I will say, as I said, there's no one way to do this. Private practice, dentist doesn't want to work on a Friday. Hygienist is there, can collect the data, see something concerning, send it to the dentist that day. The community-based programs are where probably Medicaid is going to be seen more, school-based programs, long-term care facilities, but there's no reason the rest of us can't be using this in our clinics on a regular basis, unless you're in the clinic 5 days a week and, you see every patient that comes through. But what if you're running behind for that periodic? Tell the hygienist, you know what, collect the appropriate photos, get a video, tell the patient I'm going to review it and I'll get back to them. You can use this as a way to clean up to keep your schedule on track. So don't just think about it as reimbursement purposes. Think about it as time management also.
Very good. Well, I see that we're at 1 o'clock, right on the nose. So thank you, Dr. Howell. And I'm not seeing any other last minute questions in the Q&A or chat box. So Dr. Howell will say thank you.
Thank you
so
all
much for your time today and this great presentation. We really appreciate it.
Thanks, Beth, and good to see everyone, at least your names.
Excellent. Well, thank you, and have a nice Friday and weekend.
Thank you all too. Take care.
Okay, thank you. Bye-bye.
Bye.